Food allergies affect up to 8% of infants, with cow's milk allergy, or CMA, being the most common, especially during the first year of life. Early diagnosis and nutritional management are essential for optimal care. Immune, digestive, and microbiome mechanisms are involved in the development of allergy. Allergic disease in infancy reflects a failure in oral tolerance, which is the immune system's ability to recognize food proteins as harmless. In allergic infants, exposure to proteins such as beta-lactoglobulin leads to a Th2-skewed immune response, resulting in the production of immunoglobulin E, or IgE, and mast cell sensitization. Gut barrier dysfunction and immature mucosal immunity allow antigens to cross into the lamina propria, where they trigger inflammation, setting the stage for both IgE-mediated and non-IgE-mediated CMA. IgE-mediated CMA has symptoms appearing, usually, within minutes following allergen ingestion. The immediate reactions can be acute urticaria, angioedema, vomiting, diarrhea, acute rhinitis, or anaphylaxis. In non-IgE-mediated CMA, the onset of symptoms is delayed, appearing from 2 up to 72 hours after intake. The symptoms can be vomiting, diarrhea, atopic dermatitis, and wheezing. Diagnosis relies on elimination of cow's milk protein from the diet, followed by symptom improvement. Reintroduction of cow's milk protein will result in symptoms reappearance. The reintroduction, called oral food challenge, is a common method for diagnosing IgE-mediated forms. In IgE-mediated forms, it can be accompanied by skin prick test or specific IgE testing. For all infants and young children with CMA, every source of cow's milk protein in solid foods must be removed. For breastfed babies, mothers need to eliminate all cow's milk protein sources from their diet. According to the recommendations of ESPGHAN, that is the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, formula-fed infants with CMA should receive a hypoallergenic formula, meaning one that is free from intact cow's milk proteins and has been clinically proven not to trigger allergic reactions in CMA infants. The choice of formula depends on the type and severity of the allergy. Extensively hydrolyzed formulas, EHF, derived from cow's milk proteins are recommended by ESPGHAN as the first-line option for most infants with CMA. Amino acid-based formulas, AAF, are advised for infants with severe CMA, multiple food allergies, or those who do not tolerate EHF. Rice hydrolyzed protein-based formulas are recognized by ESPGHAN as a nutritionally complete, plant-based alternative. These specific nutritional formulas have demonstrated efficacy comparable to that of cow's milk-based EHF, exhibiting high tolerance levels and providing support for standard growth across both IgE-mediated and non-IgE-mediated CMA scenarios. These recommendations provide an evidence-based approach to manage CMA in formula or mixed-fed infants, ensuring symptom control and nutritional adequacy. Emerging evidence links early life gut microbiota composition to allergic sensitization. Infants with CMA often show reduced microbial diversity, lower levels of bifidobacterium and lactobacillus, and higher proportions of Clostridium difficile and Enterobacteriaceae. The microbiome plays a critical role in promoting immune tolerance by educating regulatory T cells, producing short-chain fatty acids that enhance epithelial barrier function, and suppressing Th2 inflammation via toll-like receptor signaling. Therefore, modulating the gut microbiota is an emerging therapeutic target. For example, Lactobacillus rhamnosus GG, when added to a formula for allergic infants, has shown it can promote regulatory T-cell expansion, enhance tight junction integrity, reduce CMA symptom duration, and speed up tolerance acquisition. Also, 2-fucosilactose, a human milk oligosaccharide, which is a substrate for infant bifidobacterium species, may enable the establishment of a healthy gut microbiome in early infancy, which is particularly important in infants with CMA. Overall, for infants with CMA, it is essential to diagnose accurately using symptom history and challenges. Choose an hypoallergenic formula, including rice protein formula when appropriate. And consider probiotic supplemented formulas to restore microbial balance and support immune tolerance. A summary of the most up-to-date guidelines from the World Allergy Organization, or WAO, on diagnosis and rationale for action against cow's milk allergy, also called DRACMA. Breastfed infants with cow's milk allergy continue breastfeeding, with mothers eliminating cow's milk from her diet. For formula-fed infants, extensively hydrolyzed formulas, such as rice hydrolyzed protein-based formulas, are the first-line treatment for mild to moderate cases, while amino acid-based formulas are reserved for severe symptoms, failure to thrive, or multiple food allergies. And when choosing a formula for infants with CMA, whether IgE-mediated or non-IgE-mediated, it can be with or without added probiotics. Guidelines suggest either a formula without a probiotic or one containing Lactobacillus rhamnosus GG.